Admitting a child into the hospital can be scary for the child as well as the parent. So to gain a first-hand perspective on the type of treatment you can expect to receive at the pediatric ICU, I'm going to be talking with Amy and Emily. Hi guys, how are you doing today?
Good.
Good, so do you mind sharing with me the circumstances that led you having to check Emily into the pediatric ICU?
Emily was about 5 months old. She stopped breathing. We live about 20 minutes from here. By the time the ambulance got to us and put us into the ER, she had stabilized. We got up to the PICU, or the pediatric floor, and at that time, within an hour, she stopped breathing again. So she was rushed over to the ICU, pediatrics, where Dr. Truman evaluated her and basically got her stabilized.
I knew I wanted to be a physician when I was 18 and volunteered on an ambulance and actually got to work with patients firsthand. Pediatric critical care physicians treat critically ill and injured children, whether they're in a car accident, fall out of a tree, anything that leads them for their life to be in danger. Those are the patients that we treat. I mean, to treat critically ill children, it's best done with a team. It's important to have a pediatric critical care nurse, a physician, a child life specialist that can all come together and give the child what they need in each coming from a different perspective. But it really helps support the family and support the patient. One of the benefits of having a pediatric critical care unit locally is that the families can stay with their children, and it just is much easier on their families because often the children are only in the intensive care unit 2 or 3 days. And then they're usually better enough to go out to our pediatric floor or even go home.
We didn't know what to expect. Whenever they came in and took Emily back, the team and Dr. Truman, they took her back, got her stabilized, and was able to come out and make us feel comfortable knowing that they were there taking care of her. We didn't have anything to worry about. We were still very scared, but a lot more relieved to know that she was okay. They made me feel very comfortable, just knowing that they are watching her and making sure she has everything she needs.
If you've ever seen your child poked and prodded in search of a good vein for a successful lab draw or IV start, you'll be very happy to hear that medical advances have really taken the guesswork out of vein location, and it's all thanks to the vein viewer. The vein viewer allows healthcare professionals to clearly see accessible veins directly on the surface of the skin. The technology utilizes near-infrared light, a digital video camera, and an image processing unit to build an image of the patient's vasculature. The device then projects the image in real time onto the patient's skin using visible light and a digital projector. The vein viewer image is intuitive and the vessels are easy to recognize. When you combine the technology of the vein viewer with the comfort of Buzzy, a pain distraction device adored by children of all ages, you're able to decrease the comfort for patients and stress for their families, increasing overall patient satisfaction. If you've never heard of a child life specialist, you'll want to pay special attention to what Kendall Munday has to say, because in my opinion, the role that she plays in a child's hospital experience is absolutely invaluable. Hi, Kendall.
Hi.
So what exactly is a child life specialist?
A child life specialist is someone who reduces the stress and the anxiety of children and their families in a hospital setting.
Okay, now how exactly do you go about accomplishing that goal?
Normal play is probably one of the most important things to do. Providing that sense of normalcy is important. We also provide therapeutic activities. We also do pre-procedural preparations, and I also help assist patients through preparations.
Now, this is obviously a very child-focused area. Is all of your work done here, or do you actually go out into pediatrics as well?
We go out into pediatrics. We have the new treatment room that we just finished, so we do a lot of our procedures in the new treatment room. So I'm on the floor and in the playroom as well. I'm able to help the families and the patients with coping and provide them with those play opportunities, which is extremely important. for their development and growth in the hospital.
And what ages are you working with?
I'm working with infants all the way to patients that are 18 years old, so there's a wide range.
Now, I understand that the philosophy here in pediatrics is very family-focused, family-centered. Do you think your role adds to that?
I think so, definitely. When working with patients, it's definitely important to incorporate the family because nobody knows the patient better than mom or dad or whoever the caretaker may be. So their opinion and their insight is definitely valuable for everybody here in pediatrics.
And is it ever just play, just for fun?
It is play. There'll be days when we close down the playroom and turn it into a movie room and pop popcorn or decorate cookies just because. So normal play opportunities are extremely important for pediatric patients and their siblings also.
Great, thank you so much, Kendall.
Thank
I'll let you get back to the kids.
Thank you so much.
Tallahassee Memorial Healthcare is very proud to offer a designated Level 2 Trauma Center. So to learn more about what that means for Big Bend residents, I'm meeting up with Patty Statler. She's the Trauma Program Manager. Hi, Patty.
Hi.
So I understand getting this designation is really quite difficult. What led to going through these different hoops?
In 2005, a study was produced by the University of Florida, and they showed that the morbidity and mortality was very high in our region, which means death rates were high. So from the study, TMH said in 2006, we need to do something about this. So we began the process of becoming a trauma center. July 1st, 2009, we accomplished that mission. We became a Level 2 trauma center.
And how does that translate into the care given to the patients of this area?
When you go to a trauma center, you have optimum care. You have specially trained physicians and nurses, and the equipment is there, and everything is on hold for this trauma patient. So you get optimum care.
Now, is there a difference between an emergency center and a trauma center?
When you have an accident or something on scene, they call, the EMS comes and takes you to the hospital. If you're a trauma alert, we get a phone call and say, I have a trauma alert. I have a such and such age person and I'm bringing with this injury. All the team begins, they all get the page at that time and they become aware and ready to take care of you. So when you arrive, everyone is ready to take care of you and you are priority one.
The trauma designation is for all comers, so all forms of trauma. In our specific region, that includes the majority of blunt trauma, meaning car accidents and sports injuries, but also includes penetrating trauma, so things like gunshot wounds and stabbings and impalements, unfortunately, also occur, and we're equipped to handle all of those. The trauma center designation allows us as ER physicians to work very closely with our trauma surgeons. And having trauma surgeons on staff and available to us 24 hours a day allows us to provide very rapid care for our trauma patients and progress them to the operating room if necessary in a very short period of time, which is something that most hospitals are not able to do.
We are designated for 10-county region. We now see patients from 36 counties, so that tells you that's significant. Also, with the death rates that were so high initially, we now compete statewide.
Diabetes affects more than 25 million people of all ages. That's 8.3% of the United States population. So to learn more about this disease, I'm meeting up with Dr. Deeb right here in the Diabetes Center. Hi, Dr. Deeb.
Good morning. How are you?
Do you mind? I'm very well. Do you mind if I take a few minutes of your time?
Please.
So what exactly is diabetes and how does someone know if they're at risk?
Well, diabetes is a condition that affects blood sugar. And when it gets high enough, we call it diabetes because it can kill you, make you go blind, destroy your kidneys, cause you to have heart attacks. And people at risk for diabetes include people of minority races, people who have family members who have had diabetes, and certainly people who get overweight.
Okay, now is there a large difference between type 1 and type 2 diabetes?
Well, type 2 diabetes is in that group that I just described. Type 1 diabetes comes along because the pancreas is destroyed. The cells that make insulin are destroyed. And so it's really a very different disease. It requires insulin to survive.
Right, now is diabetes preventable?
Yes and no. Certainly, if you fit those groups, being active, controlling your weight, exercising every day, we've shown you can reduce diabetes dramatically. However, not completely.
All right, now I keep hearing more and more about pediatric diabetes. Is this a growing area of concern?
Well, diabetes in children is increasing worldwide at 3% a year. And if you're younger than 5, new diabetes cases are increasing at 5% a year.
At the hospital, they were great. We didn't even have to go check in at the main entrance. They met us up on the pediatric floor and just had the room waiting for Haley, and got there, and then our Dr. D came in and told Haley, say, you're ready to give yourself a shot. You've got diabetes. So within 5 minutes of meeting him, Haley had given her first shot, and she's given all of them since then.
I didn't know a clue about diabetes. I'd never heard of it, and so when they're like diabetes, what's that? I thought it wasn't like a big deal. You didn't have to give yourself 8 shots a day, so I was very shocked and scared too. Well, before every meal, I have to check my blood sugar, and then I calculate my carbohydrates, and I dose it all up, which tells me how much to dose, and I give myself a shot, and I do that around 8 times a day.
I'm asking you to measure your blood sugar several times a day. Think about what you eat every time you eat. Give insulin if you have type 1 diabetes or medications. The complexity of that is immense. You can't do it by yourself. You need a team. You need to learn how. And when you do, you can be successful.
From the Diabetes Center, we're going to head over to Tallahassee Memorial's Heart and Vascular Center so we can learn a little bit more about how modern technology is helping to advance patient care. Let's go. There is an approach to blocked arteries and angiograms that is pleasing both doctors and patients alike. It's called a cardiac radial catheterization, and by entering through the wrist instead of the groin, the patient may experience less pain, is mobile more quickly, and can expect a 65% reduction in bleeding complications. Here to tell us more are Dr. Katapodis and Dr. Noel.
We started doing cardiac catheterization through the wrist back in 2001. Because the wrist artery is more easily accessible and it has far less complications. And the patients can literally sit up after a couple of hours from doing the procedure and have their lunch. And it's far more comfortable, it's safer, and patients really like it. And in fact, when patients hear that we can do the cardiac cath from the wrist, if they've had them from the groin, they ask to get it done through the wrist. And now we've actually turned out to be one of the leading sites in the United States doing wrist access angioplasty and cardiac catheterization. In fact, we saw some statistics that we were in the 99th percentile across the United States of sites that do cardiac catheterizations and angioplasty through the wrist.
It was very, very easy. There was no pain and had no discomfort whatsoever. With this procedure they did now, it's I'm up, and if I wanted, I could be up moving around very easily.
A radial cardiac catheterization is where we actually place a catheter in the right radial artery, typically that's in the right forearm. The catheter tracks up within the radial artery, and we're able to place that into the coronary arteries that supply blood flow to the heart, and then evaluate the coronary arteries for significant blockages. Well, the benefits compared to a femoral approach are that the easeability for the patient to be able to be supine quickly and then stand up very quickly after the procedure. Patients seem to really appreciate that. There's less tenderness and pain after the procedure, and you're able to return to your daily activities much faster. Clearly, radial artery approaches are first choice, and I think they are going forward in the 21st century. Physicians have been really excited about it, and because of such good patient feedback, we've propagated this and provide it to the majority of our patients when possible.
Well, that's all the time that we have today. But if we must wrap up the show, I have to say that closing in this beautiful healing garden in the new Outpatient Cancer Center is really the perfect note to end on. Now, before I go, I would like to thank the many professionals that took time out of their busy schedules to meet with us today and answer our questions. I know I'm feeling better prepared about my healthcare options, and I hope that you are too. Now, if you'd like more information on the subjects that we covered today, you can go to the Tallahassee Memorial Healthcare website. It's tmh.org. Or if you'd like to review any or all of the program you've just seen, go to our website. It's localdiscovery.tv. Just click on the Spotlight for Health button. I'm Kristen Martin. I'm off in search of more answers to how we can all live healthier, more active lives. Thank you so much for watching this edition of Local Discovery, a Spotlight on Health.